Good afternoon, everyone, and welcome to this week's presentation on sickle cell disease. We thank you and appreciate your time for joining us again this week. We'll be led by Dr. Richard Vire, who will be taking us through the general concepts in sickle cell disease. Like you would agree with me, the concepts in sickle cell disease is so broad, including the various crises. I will not be able to cover into details each of these crises because subsequently in some of our presentation, you realize we would center on those specifics. So today is just to look at the general concepts. We hope to do this within 30 minutes, and then we'll be able to have some time for a brief discussion because we are involved in another webinar as well at 4 p.m. So please take note that you won't be able to unmute yourself in the course of the presentation. However, the chat box is 100% available. You could put in your comments, your questions in there, so that at the end of the presentation, then we would be able to have a discussion around it, as we always do. At the end of it as well, we'll put in a minute webinar. It just contains 4 questions. Within a minute, you'll be done. 2 of them are yes or no responses, and then the others are suggestions towards improving these presentations. Without much ado, kindly join me in welcoming Dr. Richard as he takes us off. Dr. Rich, the floor is yours.
Thank you, boss. Good afternoon. So today's presentation will be on sickle cell, and as my moderator rightly said, it will be on the general concept. So sickle cell disease is a hemoglobinulopathy which individual inherits an abnormal hemoglobin genes. So hemoglobinopathy may be qualitative or quantitative. Qualitative in sickle cell anemia and quantitative in thalassemia, which are examples. So sickle cell disease is actually a generic term that refers to a condition in which an individual has 2 abnormal hemoglobin genes, at least having one hemoglobin S and any other abnormal hemoglobin, which may result in the symptomatology or pathology which may due to the sickling phenomenon, which we'll get to know very soon. So this is a picture of abnormal and then a sickled red cell. So the hemoglobin S actually is a gene mutation in the hemoglobin synthesis, and this happens when the valine is actually replaced by glutamic acid at position 6 in chromosome 11 of the beta chain. But if lysine is replaced by glutamic acid at the position 6 of the same chromosome 11, then that one will give us the hemoglobin C. So this is a picture showing how the gene point mutation takes place. So there are different variants of sickle cell disease. So we have the sickle cell anemia, which is the SS. We have the beta thalassemia, beta plus thalassemia, beta 0 thalassemia. Then we have the sickle cell SC. So in terms of severity, sickle cell anemia is the most severe, followed by the sickle cell beta plus thalassemia. Sorry, the beta 0 thalassemia. So in Ghana, most of the frequencies, the individuals in the southern part of Ghana mostly have the abnormalities of the hemoglobin S, where most part of the population in the northern part have the abnormality of hemoglobin of C. So this is a picture that shows a data of the regional population and statistics on the sickle cell disease. So the pathophysiology, so the hemoglobin S molecule actually undergoes deoxygenation through hydrophobic interaction. And this one will change the concave shape into a sickling shape. Now, this sickling shape will now undergo the sickling, which will end up occurring or cause occlusion of the macro vessels, and then which it will in turn cause infection, leading to pain or organ dysfunction. So there are many. The diagnosis of this particular condition, there are various ways of diagnosing, but there are ones that are definitive. So we have the sickling test, which most in this part of the country or in Ghana, most people will go in for the sickling, but the definitive ones will be the HB electrophoresis and others, which we'll get to know soon. So the sickling test, which involve the solubility test and then the sickling preparation. So mostly these ones will help us to know whether the person is carrying the hemoglobin and S, because this test actually picks hemoglobin S but cannot pick the hemoglobin C or the hemoglobin F, that the fetal hemoglobin. So there's a limitation. So when the sickling is done, it's either the patient is positive or negative. And negative doesn't also mean that the patient is not carrying any abnormal hemoglobin. The patient might be carrying abnormal hemoglobin of a C or any other hemoglobin, abnormal hemoglobin. So the HB electrophoresis, there are many types, and it's actually one of the definitive diagnoses of this particular condition. There are many types. We have the cellulose acetate electrophoresis, which is the commonest that we use. And we have the citrate agar gel electrophoresis. We have the isoelectronic focusing, and we have other forms of the test as we will get to know them. So the cellulose acetate, it works in an alkaline medium. There's a limitation to this particular test because it hardly resolves hemoglobin A, hemoglobin S from the fetal hemoglobin. So this the citrate agar gel helps to resolve other variants which the cellulose acid the cellulose type cannot actually help to do. So the isoelectronic focusing is what is superior as compared to the two. So this one actually helps to this one actually helps to separate the other hemoglobin from the fetal hemoglobin. That's the hemoglobin F. So which makes it more superior to those that have been mentioned already. It is also a type of confirmation hemoglobin test. So we have the high performance liquid chromatography. So this one is also a very high diagnosing form of diagnosing, but it comes with its own challenges because of the expensive how expensive the equipment are, and then it needs a lot of technical know-how. So this one is also used in newborn screening, actually which helps to pick up this condition in early stage. So we have the DNA testing, which needs no other confirmation, and also doesn't need any parental testing. There are other few ones that we may know. That's the prenatal diagnosing, taking the fetal blood sample, and then making a DNA typing from amniocentesis. So this condition comes with have some clinical features and complications. So the condition affects almost all organs in the body. The severity may vary and can be influenced by other factors. And these factors can be infection, or if the patient has other red blood cell enzyme deficiency like G6PD, which may increase the complications of the patient. So there are other environmental factors too that may also worsen or increase the severity of the condition. Patients who have good nutrition may have less complication, or the crisis may not be that severe. Patients who are diagnosed very early and then managed very early may also have mild complications or symptoms as they grow up. So one of the complications, or one of the characteristics of this particular condition, is the vaso-occlusive crisis, which is also called the painful crisis. So there are two types. You have the acute and then the chronic complication. So this actually happens when there's an occlusion of vessels by the sickled cells, resulting in pain from ischemia. So this particular, it happens mostly in long bones, in long bones. The abdomen may also be involved, and in the chest also. There are other factors, as I already said, that would may precipitate or increase or worsen the condition, which are infection, physical exercises, exposure to extremities of weathers, that's cold or very hot weather, fever, dehydration. Women who are in their menses and then have this particular condition may also be tipped into crisis. People who also abuse alcohol may also have repeated crisis. So the pain may be unprovoked and may have no warning signs. So the pain may be mild, moderate, or severe, and this will help us to know the management. So under narrating the severity of the pain may lead to under treatment of the patient. So the early part of this particular complication, that's the vaso-occlusive crisis, is those in children that happens in children, and that's basically one of the first signs that may happen in patients with this particular condition. That's the hand-foot syndrome, or the dactylitis. Patients with this particular condition may come either with abdominal pain, or chest pain, or priapism, which may coexist with this bone pain crisis. One of the things that we should also know is that aside the crisis, patient may also present with other conditions which may not actually be as part of the crisis. So in the course of examining and taking history, we should have other differentials in mind, so that not to miss other conditions that may have similar presentation as the vaso-occlusive crisis, like the acute abdomen, osteomyelitis, osteoarthritis, and others. So there are other acute episodes. That's the acute anemic episode. They have different crises that may come along with this particular acute episodes. So we have the hyperhemolytic crisis. So mostly the red blood cells, as you know, has a lifespan of 90 to 120 days. But with the defective hemoglobin, that's the hemoglobin S, it has a lifespan of average of about 17 days, which increases the hemolysis rate. And one of the things that may increase this hemolysis rate, as I already said, is infection or any other red blood cell enzyme deformities, such as the G6PD, which may also worsen the hemolysis crisis. So patient with this particular hemolysis crisis may come with fall in HB, fall in the PVC, increased retic counts may also be one of the things that may be picked up in laboratory test, laboratory investigation. Patient may present with hepatosplenomegaly. Patient may look pale or jaundice. Patient may present with dark dark colored urine or Coca-Cola urine. There's another type of crisis that is the aplastic crisis. So actually, this is when there's an acute failure of the erythropoiesis, and when laboratory tests are done, one of the things that some of the things that will help us to know this particular crisis are the laboratory test may show a very low HB, very low PVC, or there's no retic count, or the patient may have very low cell count. So patient with this particular crisis, one of the things that will be associated or the risk factors of this is some viruses. That's the parvovirus 19 B19. So this actually is mostly associated with this particular crisis. Aplastic crisis may come along with other crises of sickle cell disease. That is the acute chest syndrome, acute sequestration of the spleen, pain, that is the pain crisis, stroke, or in other crises that may be associated with this aplastic crisis. So one of the major treatment for this aplastic crisis is transfusion, especially when the patient is hemodynamically unstable. The transfusion is ideal in this particular crisis. So acute sequestration crisis actually happens when the patient has an enlarged and then painful spleen. Patient may also present with shock in such crisis. So the spleen may become enlarged more than 2 centimeters. There may be a drop of HB more than 2 grams per deciliter. The patient laboratory findings may also show thrombocytopenia or reticulocytosis. Sequestration of the liver may also occur in some cases. So patient with with sickle cell disease and who are also in anemic episodes, one of the things that you shouldn't also forget is that they may be reduced in folic acid because of the increased hemolysis. So patient may come with megaloplastic anemia. Another crisis, which is one of the severest and is one of the cause of death in patient with sickle cell disease, is the acute chest syndrome. So acute chest syndrome, patient may complain of chest pain, fever, and there may be signs of respiratory distress. Now, one of the things that we'll see on the chest X-ray is new pulmonary infiltrates. So when patient comes with it and clinically we pick up that it is acute chest syndrome, patient is supposed to be treated as infection, pneumonia, or an infection. So antibiotics, analgesics, and then hydration is key in this particular case. If it is severe, the severity of the crisis, hemotransfusion may also be indicated in this particular crisis. So this is the clinical presentation that may come along with this crisis. So the patient might be febrile, may come with cough, chest pain, shortness of breath, wheezing, hemoptysis. So on a clinical examination, patient might be febrile. So chest tightness may be there. Pulmonary examination may be normal or abnormal, with abnormality of wheezing or dullness to percussion. So as I already said, it's acute chest syndrome, as I said, is a definition of a new infiltrate on a chest X-ray, with or without respiratory symptoms, with or without chest pain, with or without leukocytosis. So the cause of this is actually multifactorial. So infection, in fact, thrombosis or embolus may trigger this particular crisis. So the chest findings may be, the infiltrate may be unilobar or multilobar infiltrate. Pleural effusion may also be picked up from the chest X-ray. We shouldn't also forget that on auscultation, we might also pick fine crepes, which may denote pulmonary edema. So as I said, in this particular crisis, we treat the patient as an infection. So antibiotics is key. Oxygen supplement, that if the SpO2 is low, is low, analgesics shouldn't be a patient shouldn't be denied of analgesics. In some cases, bronchodilators may be used in these patients. Hemotransfusion, as I said, may be given, either simple or exchange transfusion. So this patient with sickle cell disease are mostly prone to infection, and strep pneumonia and Haemophilus influenza B are actually implicated. However, because of immunizations, these particular organisms are mostly not, or nowadays are not mostly implicated because of the immunizations. Salmonella and other bacteria are also implicated in this particular causes infection in patients like this. They are also prone to viral infections. Parvovirus B19 is, as I said, causes the aplastic crisis. Patient sickle cell patient, when they come, we shouldn't forget to screen them for hepatitis C, especially because they are actually prone to hepatitis C infection. Malaria screening should also not be forgotten in patients with this condition. So patients are actually prone to infections because of, most of them at the early stage of the condition, they may end up having splenism or dysfunctional spleen, defective opsonization, abnormal phagocytic function, and other reasons why the patients are prone to infections, such as impaired humoral antibodies response. Patient may also present with genitourinary symptom complications. So patient with a sickle cell disease, especially patient with sickle cell SC, the SC type are mostly prone to renal medullary carcinoma, one of the carcinomas actually picked up in sickle cell diseases, and which are mostly common in an SC patient with sickle cell SC. So priapism is also one of the complications in patients with sickle cell disease, which there are actually two types. We have the stuttering type. We have the stuttering type and then the refractory type. So the treatment is actually conservative: pain management, hydration, transfusion, alkalization. In cases that all this, the conservative management is not resolving, or is not making the priority to resolve, then surgical management is also brought in. That is, we aspirate. There's an aspiration of the blood using through the corpora. Patients with sickle cell disease, when they come to our clinic or when they come and complain of visual impairment or visual disturbance, we shouldn't forget that it's one of the complications that they can also get. They are prone to this particular complication, sickle cell retinopathy, and this is also common in people with sickle cell SC. So people with sickle cell SC, when they come and they complain of visual disturbances, we shouldn't forget to screen them or refer them to the ophthalmologist for further management. So stroke, which is also a complication of this particular disease. So patient may come in a complication of stroke, either hemorrhagic or infarctive stroke. So patient with when patient comes, one of the things we have to actually do a CT, an urgent CT, to know what type of stroke it is, and then to know the appropriate management for such patient. And then hydration and transfusion may be needed in managing as part of the management of the patient. So to actually pick up risks in patients who are prone to stroke, we do the transcranial Doppler scan. So they are when the abnormalities, when it is more than 200 centimeters per second, then we should be worried, or the patient has a risk of developing a stroke. So there are also other complications that may be involved. The bone may be involved. So we have the avascular necrosis, which most patients may come with as having difficult pain in the hips. So we have osteomyelitis, which is salmonella is actually implicated in this particular condition. Leg ulcers are also part of the complication. Therefore, patients with leg ulcers, we shouldn't forget to do our Doppler to rule out DVT, which will end up causing PE, because patients of such sickle cell disease are mostly prone to pulmonary embolism. So management of sickle cell disease, it is actually a multidisciplinary approach, because the complication is involves most of the systems, and we need other disciplinary approach to help solve these particular issues. We need the hematologist, we need even the psychologist, we need the orthopedic surgeon, we need a surgeon in terms of splenotomy, we need the orthopedic surgeon in terms of avascular necrosis, we need the ophthalmologist in terms of the retinopathies, we need the urologist in terms of renal issues. So patients with such condition, a detailed history is taken, especially patients who don't know their status or their genotypes. And in this particular part of the world, most patients don't know their genotypes even from birth until they enter into crisis. And then most of them, especially the sickle cell SC, they come in crisis in the early stage of their life. So it is during admission and during investigation that these genotypes are picked up. So in a detailed history, we should find out a family history, whether there's any person with sickle cell disease in the family, or the patient has an idea or has a sickle cell, knows his or her sickle cell status. So whether the patient has been to the hospital on some of the crises. So physical examination, as I said, it involves all the systems. So in examining the patient, we should examine the patient through all the systems to pick up any complication or to pick up any further complication, which may not even be part of the presenting complaint. So investigation. So patients who don't know their genotype, we do the diagnosing test to actually confirm whether patient is a sickle cell patient. If patient is a sickle patient, then we do other labs to see if there are other end organ damages. So the full blood count is needed to know to see the level of the HB, WBC, and its differentials, platelet counts. We need all these things even in management of the patient, and subsequently we need it in putting patient on other treatment. So malaria parasites show, because these patients are mostly prone, especially the sickle cell anemia patients are prone to malaria infection. Chest X-ray shouldn't also be forgotten, especially patients in acute chest syndrome. Liver function test should also not be forgotten, because some of these patients they have hepatic issues. They come with acute cholecystitis, so shouldn't also forget about liver functioning test. Then our normal urine RE, DU and creatinine should also be should not be forgotten. So treatment. So treatment of patients with sickle cell who come into crisis. One of the things is that hydration is a key. Is a key thing in management. Pain management is also one of the things that is needed. Antibiotics, if indicated, especially in acute chest syndrome and any other, or if patient has any other infection. So if patient comes in respiratory distress, especially in acute chest syndrome, oxygen therapy is also needed. Blood transfusion, which is mostly indicated in acute sequestration of the spleen, acute chest syndrome, aplastic anemia, aplastic crisis, and then even in strokes. So transfusion is needed in some of these crises. So there are new therapies in sickle cell disease. So the first, and then what the one of the treatment modalities, that is the hydroxyurea. Glutamine may also be used if patients are actually hydroxyurea is contraindicated in the patient, and other medications may also be used if patients hydroxyurea is contraindicated. One of the major way, or the way of curing this particular disease is bone marrow transplant. So hydroxyurea actually is the choice of preventive therapy in patients with this particular disease. So the mode of action, it is a ribonucleotide inhibitor that interferes with the S phase of cell cycle. So it leads in another thing to it also leads to the increase in the synthesis of hemoglobin F, which is actually helps to reduce the number of times the patient enters into crisis. So there's decrease in polymerization, which is one of the which is one of the ways of the pathophysiology of the crisis. It decreases neutrophil counts. There is also increase in WBC hydration, increase in WBC deformability, prolonged WBC survival, decrease in hemolysis, and other mechanisms. So before we put patient on hydroxyurea, there are key testing that we have to do. The full blood count, which is necessary to actually know the WBC in the red blood cell indices. That's the patient's baseline HB. So you also have to know the WBC of the patient. That is the white blood cell count, and then its differentials. Platelet count may also should also be noticed, or should it's one of the things that we need before we put patients on high dose urea. Reticulocyte count is one of the things that we need to before we put patient, and then the percentage of fetal hemoglobin. So these three things, parameters or labs, are supposed to be done before patient is being put on high dose urea. Patients who are in their reproductive age, pregnancy tests should not be missed, because high dose urea is contraindicated in pregnancy. So one of the contraindications in pregnancy, as I said, pregnancy, if patient is already allergic to high dose urea, and then if patient, after the baseline testing, we find out that patient is having pancytopenia, then patient is not a candidate, or is not a candidate to this particular treatment. So there are a lot of clinical benefits. So one of the clinical benefits that it decreases the vaso-occlusive crisis in a patient, acute chest syndrome. It also decreases the stroke in patient. It improves end organ, prevent end organ damages in patient with sickle cell diseases. It reduces the hemolysis crisis, the acute sequestration of the spleen. It also reduces the number of times patient is hospitalized, because the number of times that the patient enters into crisis is reduced. So generally, the patient life, there's an improvement in patient quality of life, because patient doesn't enter into crisis because of the high dose urea. There are few side effects of this high dose urea. So mostly patients who are being put on this particular medication may come with pancytopenia. That is the reason why we should do the baseline to actually know whether patient is in a pancytopenia, is pancytopenic or not, before we put the patient on it, so that in the course of the treatment, patient, if full blood count is repeated and then we find this, then we can actually stop patient or stop treatment. So patient may also come with skin and nail pigmentation. It is also documented that there is infertility in men, in men who are on high dose urea. So there is an impairment of spermatogenesis. There's actually no documentation on infertility in females. So patient with who have end-stage renal failure care should also be taken in putting patient on this high dose urea. So patient may be put on half of the medication of the normal dose, or patient who don't have any renal impairment. So a bone marrow transplant, as I said, is the cure for this particular sickness. So actually, there are few percentages, or that shows that 90% there was 90% when it was done in some few centers in US. It was the success rate was about 90% and 80% in some centers in Europe and in Europe. So there are few challenges with this particular bone marrow transplant. That is complication as graft rejection and interstitial pneumonia. The best time for this for bone marrow transplant is in childhood, but currently there are research that is being done to see how bone transplants may also be done in adults. So patients who have such who have sickle cell diseases, in their management or after they are being discharged from the clinic, the few follow-ups that they need to be cancelled, or they need to be cancelled, and be educated on their triggers, which are the prevention of infections, hydration, good hydration, and then abstaining from any very stressful exercises. So, and then there should also be family screening and then genetic advice. Patients should also be put on some prophylactic antibiotics and immunization, as I already said, which is one of the things that are being introduced in the immunization programs. So growth of children should also be monitored, because one of the complications is that children with this particular condition end up to be retarded in growth. So this patient also need a dietitian or a nutrition consult to actually help them in their nutrition or in their dietary habit. Folic acid should not be forgotten in patients who present to our clinic, because the continuous hemolysis may deplete their folic acid stores. However, one of the things we also should also know that patients with such conditions we should be very careful in putting patient on iron supplements. So patient with such crisis, we should not put patient on iron supplement, because the continuous hemolysis may already predisposes the patient to iron overload. So putting patient on iron supplement may also increase the iron overload, which may end up causing a lot of renal and other complications. Thank you.
Thank you, Dr. Richard, for a good job done. So already there are some questions and comments in the chat box. I'll just go through those ones. We have about 18 minutes to have a discussion around it. And then if you do want to make a comment or ask a question, you could electronically raise your hand, and then I would unmute you so that you could go ahead to do this. Also, like I indicated at the beginning of the presentation, we would want to evaluate what Dr. Richard has done, like we always do. So kindly click on the link I've just put in the chat box. It just takes a minute, and then you provide us with your responses. There are only 4 questions. 2 of them are just to pick a measure, and then the other 2 are about suggestions for improvement. Thank you very much for responding to that quick survey. It just takes a minute to do this. So I'll go through the questions in the chat box once I don't see any hand up yet. The first one is from Yao Sapong. He's asking, why is sickle cell disease patients at risk of hepatitis C virus infection? Dr. Richard, do you have an answer?
Boss, really, I didn't find out the reason, but I know one of them, they are really at risk. So they are really at risk, but I didn't find out the reason why they are really at risk.
So it's about the continuous transfusions. Before the advent of screening people for hepatitis C or screening blood routinely, a lot of people got the blood-borne viruses, the BBVs, including hepatitis C, regards continuous chronic transfusion that they are on. It's just the same risk as carried by those who use intravenous drug or they abuse them, the IVDA, intravenous drug abusers. So it isn't only about hepatitis C, but the blood-borne viruses, because they would, in a way, be chronically transfused. This risk is actually lower now that we screen a lot for these diseases. And so it's not so common to have a blood transfusion. The other things are with regards to the fact that they would almost always be in hospital for one reason or the other and requiring parenteral medications. And anytime you have a foreign object getting into the veins, your risk of blood-borne viruses increases. Of course, we try to do these things as aseptic procedures as much as possible, but it doesn't take the risk away 100%. So these are some of the reasons why those who have sickle cell disease, especially those of them who keep getting frequent crises, may be at risk of picking one blood-borne virus or the other as a result of the various procedures and measures that are done to help to reverse the crisis. The next question is from Charles. He asks, can sickle cell disease cause infertility in both men and women? Dr. Richard, do you have an answer?
So, because I in the course of the presentation, I said research has shown that infertility is actually has been documented in men, but in women, there's no strong evidence of infertility in females, but there's evidence of infertility because of the impaired spermatogenesis in males.
Yeah, I think you are talking about in the case of the use of.
Yes, the use of the hydroxyurea, but in general, sickle cell, but
Genesis is put in
yes,
as one of those.
Yes.
But he is asking about sickle cell disease itself. So the thing about hydroxyurea, again, is that there's really nothing to be so much afraid of. The reported incidences of infertility with it is quite rare. And obviously, it is not something to be afraid of. And so we are not afraid to, if you are a candidate for hydroxyurea, as is recommended now for everyone, that we do give that to you. Obviously, what you really need to do is to monitor and have your baseline test that you have already highlighted. With regards to his question, which is not on hydroxyurea, but rather on sickle cell disease causing infertility, like Dr. Richard mentioned, there's priapism, and this results in impotence. Obviously, if you are impotent as a man, it will be difficult to fertilize a woman. So this, in a way, can cause that. Again, with regards to the women, of course, the frequent crisis and all of that does put you at risk. And then also the loss of blood through hyperhemolytic crisis as well may make you suboptimal, but it doesn't really have a direct sort of risk on your fertility. And so these are things that usually we would counsel patients appropriately about, how to prevent the various crises so that then you don't get impotence as a man with priapism that is not adequately catered for. His second question is asking, it is sometimes reported that sickle cell patients do not often contract malaria. How right is this assertion? Dr. Richard, do you want to take that?
So it is the sickle cell trait that don't contract the malaria, not the sickle cell disease patient.
Great. So usually we are careful to bring out that one of the things that actually precipitates the crisis is malaria. And so sickle cell disease patients are advised to observe the various protective measures, even more than the general population. So like we always recommend an insecticide-treated bed net for them to sleep under, especially in the days or the season, the malaria season. Once you have malaria, it may predispose you to one crisis or the other, which we don't want you to. Now, the other thing is with regards to the fact that the sickle cells, the sickled shaped cells, make it difficult for the malaria parasite to survive in. And so that may account for why some people would say that they commonly don't get malaria, but it is not that they don't get it. When they get it, it becomes very severe. It's just about the ability of the parasite to survive in there because it requires a lot of oxygen. And you and I know that if you have sickle-shaped cells, once the oxygen tension goes lower, they become sickled. and the parasite may not be able to survive. It also holds for those who have the trait, the sickle cell trait, either an AS, an AC, or any of that. So they, again, because of the fact that they do have some crisis under very low oxygen tension, and so they may also tend to be a bit, not commonly get malaria, but again, we ask them to observe the various preventive measures. So we will not advise people that because you have sickle-shaped cells, you should go around exposing yourself to malaria parasites. When you get it, it becomes really very severe and can actually lead to a mortality because it's a common cause of the various crises that he enumerated. So the next question is asking about an age limit to the use of hydroxyurea. If you can please take us through the doses. So obviously there's an age of start. The current recommendations says that for children, usually more than 9 months, hydroxyurea is recommended for all of them. So between 9 months and 2 years in the developed world, they give to everyone. The issue is about availability and monitoring and the need for a specialist care when you are on these. It's also recommended for all adults. Back in the days, we used to look for indications for sickle cell disease people for the use of hydroxyurea. Now those have been taken off. So all adults who are candidates for it, except you have a contraindication. So it is no more that we are waiting to have one severe case of acute chest syndrome, which was somewhere in the 2015 recommendations, or you wait for 2 vaso-occlusive crises requiring admission. These are all recommendations. So if you talk to the hematologists and those who are experts at managing sickle cell disease, they will tell you that the newer recommendation just recommends it for everyone. So children 9 months to 2 years, and adults and adolescents is recommended, except you have the contraindications Dr. Richard did enumerated in his presentation. Regards the doses, you may have to refer to that because usually we start off at a certain dosage and then you step it up from there. In actual fact, we don't recommend that general practitioners will start anybody on hydroxyurea. It will be fair to have him seen by specialists so that then the various baseline things can be done and then the monitoring can be done, because it's actually a drug that is very useful but can cause a lot of problems. And so we are careful in probably giving out doses that you just need to start someone on. But if you wish to know, it's about 15 milligram per kilogram body weight as a single dose for an adult. And typically we monitor the patient's blood cell count every 2 weeks. And then you titrate the dosage by about 5 milligram per kilogram body weight per day. Typically, the things we monitor are those that Dr. Richard did mention. But one of the things that we have to be careful about is that we don't increase the dose if the blood cells are within the acceptable range. And also if there's toxicity from it. I think Dr. Richard also mentioned that. All right. I think we are done with those questions. Dr. Salam asks, though CC will not fit into the definition of sickle cell, is this compatible with life? And if yes, are there any documentation of an individual with CC? And if no, why is it not compatible with life? So there are people with CC. Some people say that it is not compatible with life, but I've not seen any evidence. I've actually had some patients that they did the genotype and we saw CC. I don't know if it's a lab error or not, but those guys are there. And I don't have a reason why it is not compatible with life as ascertained by some resources. Number 2 asks that, can you kindly highlight the indications for hydroxyurea? I think I just highlighted this, that now we don't look for indications for hydroxyurea. It is for everyone. Back in the day, about 5-6 years ago, people in medical students exam or in residence exams, they would ask you about indications. Now, those who manage sickle cell disease will tell you that everyone is a candidate for hydroxyurea. Rather, we look out for why not on hydroxyurea. Then the comment, as a clinician, we should be watchful of using terms like infertility. The preferred term is subfertility. Thank you very much for bringing that out. Then Madam Doris asks about, some time ago, I was made to understand hydroxyurea causes priapism in patients. What do you say about this? So like we did indicate, sickle cell disease does cause priapism, and hydroxyurea through its mechanism of action. Some people did allude that in rare cases, you can have priapism as a side effect, but the incidence is less than 1%, and it's actually classified as among the rare side effects of hydroxyurea. Again, like I indicated, usually we would want to have patients started on this under specialist monitoring. There's one from Elizabeth. Great, we are learning. Thanks to the team. Thank you very much, Elizabeth. Sani asks, great presentation. Is there a criteria for sickle cell disease with acute splenic sequestration to undergo splenectomy? Yes, so there is. I think the surgeons do have that criteria, and you can probably look at it. One of the things we are going to present on is that crisis, acute splenic crisis. This will be tackled thoroughly as well. The last time I checked the life expectancy of sickle cell disease, it was around 25 to 30 years. Now better is it now, please? I don't get it, but I guess that you're asking whether there's improved life expectancy. One of the things that has improved the life expectancy now, which we are looking at about 50, that's double the age that you did mention, has been the preventive measures and the use of hydroxyurea, and then the human stem cell transplant, which is the definitive cure. In terms of the pain management, which analgesic is more preferable, opioids or NSAIDs? So it usually depends on the severity of the pain, right from paracetamol to the NSAIDs to the opioids are all indicated depending on the severity. So usually we want them to classify the pain scale from 1 to 10 is a key term. And based on that, we will appropriately intervene when necessary. Please, is hematuria common among pregnant women with sickle cell disease? So it's one of the things that pregnant women with sickle cell disease can present in, like especially those with the SC genotype, like Dr. Richard did put in. Some do have, well, renal cell or renal medullary carcinoma. This also holds true for those with sickle cell trait, that is those with AS or AC. Sorry, I joined late. I just said Dr. Richard mentioned priapism. I think we tackled that one. Please, how will one treat sickle cell pregnant woman with VOC? So again, we are going to present on that as well. The key is the general things, all the things that Dr. Richard did mention, the general measures apply to both pregnant and non-pregnant women, as he has highlighted. Is hydroxyurea readily available in the Ghana Health Service System? I understand it's been sponsored by some NGO. Yes, Emmanuel, that's true. It's very much available. And under the NGO, it's not an NGO by a pharmaceutical company. It is for free. Recently, the Vice President of the Republic did mention that sickle cell disease has been placed on the National Health Insurance Scheme for free, and the drug hydroxyurea has been. But this is a policy pronunciation rather than the practical basis on the ground. The pharmaceutical company, gracious enough, has continued to supply it at the specialist clinics so that then patients are appropriately monitored and treated appropriately if they need the hydroxyurea. So this is all for free. Does sickle cell disease affect mental capabilities? And if yes, what's the severity? So the continuous, like you did here, Dr. Richard mentioned about transcranial Dopplers and the use of it in those who have sickle cell disease, where things are done right. Most children, we do the TCD for them because they do have some microinfarcts, and this does, of course, affect mental capability or your intellectual discourse. Again, there's what is called your work off days or school off days, which goes in a long way socially to affect how the children perform in school as well. Please, do we have intermediate remedies for their babies? I don't get that question, but again, the general measures apply to children with sickle cell disease. I was hoping for him to talk about pre-counseling and pre-testing for couples who intend to marry to undergo sickle test to be compatible. That's true, and like we indicated, sickle cell is extremely broad. We couldn't cover all of that, but it's key that if you have the trait that is either an AS, we would usually advise that you undergo appropriate counseling, pre-genetics, and then, of course, as an adult, you decide what you want to do with your life. There's currently no law barring those who have the trait from marrying, but you provide your medical counseling and based on the various medical ethics, and then the patient is appropriately guided to make an informed decision. Please, Doc, I want to know as a healthcare giver, precisely as a midwife, if you encounter with a pregnant woman who is already in crisis, how do you manage such a client while waiting for medical team? So the same measures Dr. Richard mentioned, the general measures will apply. And then we'll say that a sickle cell disease patient who is pregnant is a high-risk pregnancy, and so you should refer to see an obstetrician, gynecologist for antenatal care. Bintu Dasas, please, aside the bone marrow transplant, is there any other form of complete treatment for people with sickle cell disease? Like we indicated, the definitive or the cure for sickle cell disease, human cell transplant, but the other would include hydroxyurea and all of that we said. Please, at what age you can't use hydroxyurea? So typically, it depends on what we call the steady state hemoglobin of the patient. And that's why we need those baseline tests to be able to. Unfortunately, we've gotten to a minute after 4. Our other presentation has just started, and so we won't be able to admit people to ask questions, but we'll be able to address all the questions in the chat box. Thank you very much for making time with us. Next week, we'll come your way again with another presentation. You'll see it on the various platforms. Take very good care of yourselves, and God bless. Bye-bye.